Chapter 6, Assessing the General Survey and Vital Signs. So, surveying the whole person, when we're talking about general survey, we're talking about assessing the general well-being and behavior of the patient. And we usually get this information when we are first encountered with them, also by collecting their health history. We are instrumental in collecting both subjective and objective data, and of course it always begins with your subjective data. And you're using your sense of sight, your hearing, your sense of smell as part of your inspection to collect information about the general survey of your patient. And so when we talk about general survey, we're talking about a couple of different facets, both physical appearance as well as their behavior and mental status. And again, this is all probably collected when you first see them, when they first enter into your office, and while you're collecting your health history. And you're getting information about their health and how they define health and their general well-being, what they consider health to be. What their age is and where they are developmentally. Are they appropriate for the age that they are? Are they acting appropriately? Are they beyond, or are they regressing to a younger age? If they're an elderly person, what age do they see themselves as? What is their overall hygiene and grooming? And that also goes along with, is there any body odor? So you're looking at the patient, you're kind of looking at the clinical picture and identifying, well, if they're homeless, then of course maybe their hygiene and their grooming and their body odor, may need some help. So is it because they are homeless, or do they live in a residential community, but do they need assistance with hygiene, grooming, and body odor? And so those are things that we take into consideration. What is their body structure like? What is their mobility and posture? And a lot of this is, when they enter into the room, what is their gait like? It's part of our assessment of their neurological system, but it's also part of our assessment of their general survey. Are they able to move? Do they need help getting up on the table, or do they need help sitting in a chair? What is their posture like? Is it upright? Are they slouched over? Are they slouched over because of age and osteoporosis, or are they slouched over because of back pain or lumbar pain? Do they exhibit signs of distress? Are there any physical or emotional signs of pain or distress? And then we also want to collect information on their level of consciousness, and that goes along the lines of, are they alert, awake, and oriented? Do they know where they are? Do they need somebody to speak on their behalf? Do they know what day of the week it is? Just by asking simple questions, you can gather that information. What is their behavior like? Do they exhibit physical expressions, and are those physical expressions similar to what they're speaking to you about? So for example, if they're talking about maybe their grandparent and they're talking about the birth of their grandchild, do they exhibit the appropriate facial expressions and mood that is appropriate for somebody who just became a new grandparent or has welcomed a new grandchild into the world? And then what is their speech like? And in terms of speech, are they able to articulate words? Are they having trouble? Is there slurring of speech? So all of these, the physical appearance as well as their behavior and mental status, gives us some insight into their state of being. The next part of our assessment is, and it's really the next step of our assessment, is the collection of vital signs. And when we collect vital signs, we're collecting their temperature, their pulse, their respiratory rate, and their blood pressure. I'm going to talk about pain in a separate slide deck, chapter 7. But pain is also considered one of the vital signs. When we're collecting their oral temperature, we can collect temperature in general, orally, tympanically, temporally, as well as rectally, and the more common, as well as axillary. But the more common of all of them is the oral temperature. And by assessing the oral temperature, we can use a disposable thermometer or an electronic thermometer probe. Patients with an accurate reading should not have smoked or consumed any hot beverages or cold beverages within the last 30 minutes, because that can give you a false reading. When we're assessing temperature orally, we need to make sure that that thermometer has been charged if it's digital. And if it's disposable, we need to make sure that it's calibrated, that it's at its lowest reading before we place it in their mouth. And when we're taking it, we're taking the if it's a digital assessment, we're taking a probe and we're placing it over the digital probe as they're disposable. So it's one patient at a time. We're asking the patient to open their mouth, lift their tongue up, and then we gently place it right underneath their tongue and have them close until a calculation is made. Normal temperature findings, especially with an oral temperature, is between 97.5 to 99.5. Anything below or above those types of readings is considered abnormal. Could they be hypothermic, hypo meaning less than, or hyperthermic? Could they have a fever when it's over? We also assess temperature by way of the tympanic probe. We use the tympanic probe uses an infrared radiation and thermopile detector at the tip of the tympanic probe in order to measure the core temperature, and it's usually completed within 3 seconds or so. And by doing this, what we want to do is we want to gently pull up and back on the earlobe and then apply the probe with a new sheath towards the temporal region. And normal findings for this type of temperature in the tympany or the tympanic membrane is 98.2 to 100, and it's usually about you're a little bit warmer than your oral temperature. Abnormal is less than 98.2 or greater than 100. Temporal temperature is taking a temperature by way of applying a probe and then grazing it over the temporal lobe to the alternate temporal lobe. This also uses infrared heat waves that run across the forehead just below the skin, and it reads in the direction from right to left or left to right. Normal readings for this, 98.7 to 100.5, and anything below or above is considered abnormal. And then the last that I'm going to be discussing today, that's also mentioned in your book, is rectal temperature. And we usually don't do rectal temperatures routinely. These are only done when we're concerned about a patient's core body temperature, or we're unable to do an oral temperature, they're not able to cooperate with a tympanic, or we don't have a temporal temp. Or if the patient is severely hypothermic or hyperthermic, that we really need to assess the core body temperature. And again, this is probably your most accurate temperature reading. Just kind of be aware that it can stimulate the vagus nerve, so it can be contraindicated in some patients. When you're taking a rectal temperature, obviously you're using gloves, you're using a disposable tip on the thermometer, and that thermometer has to be lubricated. And you really need to make the patient very comfortable and kind of educate them as you're inserting the probe. And you don't want to insert it completely in. You want to insert about 1 inch into the rectal region. The most accurate reading is your rectal thermometer reading, and again, 98.7 to 100.5 is usually the normal range. So let's start with a question. You're assessing the temperature on a 32-year-old woman who is alert and oriented. They report that they just had a cup of coffee to drink while waiting to be seen by the doctor. Which thermometer assessment would be appropriate in this scenario? If you said both C and D, you are correct. Both the tympanic as well as the temporal are the most accurate. And remember, we said within the last 30 minutes, we really shouldn't do an oral temperature because that's only going to give us a false reading. So the next set of vital signs that we collect is the pulse, and we assess actually pulse and respiration simultaneously, or actually one and then the next one. But pulse is the assessment of the heartbeat through the wall of the radial peripheral artery at the wrist, and the most common region to assess is the radial artery right on the wrist, right below the thumb region. We'll use a watch or a clock with a second hand, and there are two locations to assess the heart rate. And again, that's the radial and then the apical, which is at the fifth intercostal space, mid-clavicular line. And the apical pulse is most commonly assessed by using your stethoscope. And so in this picture, you'll notice the radial pulse is being collected here, and you're using the nursing skill of palpation, and you're lightly palpating, and you're assessing the rhythm, the quality. Is it a normal pulsation? And you really should count for 60 seconds as you're assessing a patient's pulse. Normal findings for a pulse is 60 to 100 beats per minute. Well-conditioned athletes usually is on the lower range, and so 40 would be considered a normal range for them. Anything less than 60 in an unhealthy individual or greater than 100 are considered abnormal findings, and that's what we would call bradycardia for less than, and then tachycardia for greater than. If the rhythm is irregular, or if you feel like you're palpating and it's as if there's a skipped beat, we would want to confirm that with an apical pulse as well. And the amplitude should be, it shouldn't be thready and it shouldn't be bounding. The apical pulse, again, assessing the heart rate at the apex of the heart, and the apex is at the fifth intercostal space, mid-clavicular line, and we're going to reinforce this information when we talk about the cardiovascular system. Same thing, in this case, we're using a stethoscope. We can use our fingers to palpate. It's just going to be a little bit more difficult to really palpate. But in this case, we use our stethoscope, and we count for 60 seconds. Again, no change. 60 to 100 is normal, and the rhythm should be regular. And the region is right in that area. Pulse deficit is assessed if the pulse seems to be irregular or weak, and it could be related to the heart's inability to pump blood. And this, can be found in patients who have cardiac arrhythmias, murmurs, atrial fibrillation, mitral valve regurgitation, or they may have decreased peripheral perfusion or inadequate arterial perfusion. And we're going to talk a little bit more about this when we get into the peripheral vascular system as well as the cardiovascular. But just remember that pulse deficit can be assessed. And all it is you're just determining the difference between apical as well as radial pulse rates. So let's go on to our next question. So you're assessing an 88-year-old man and obtain the following vital signs. Tympanic temperature, so ear temperature, 97.2. Left radial pulse, 66 and irregular. Weak with some pauses. Apical pulse is 72. And you notice that there are skip beats when you auscultate. So therefore, what is the pulse deficit and what is the pulse amplitude? And I'll give you a moment to try to come up with this answer. If you answered D, you are correct. Remember, the pulse deficit is the difference between the apical pulse and the radial. So all you need to do is subtract 72 from 66, which gives you 6. And then weak pulses are +1. Thready pulses, weak pulses are +1. 0, or if you don't really feel a pulse, then we consider that a 0. The next nursing skill for vital sign collection is your respiratory rate. And with respiratory rate, we're assessing pulmonary ventilation. And of course, we have, the pulmonary system that we're going to go over. And in this case, we would kind of do it simultaneously with after our assessment of the pulse. We don't really want the patient to really know what we're doing because we don't want them to alter their breathing process. And so one breath is considered but one inspiration and expiration. And respiration can be influenced by a number of different factors. These include exercise. If somebody just worked out, their respiratory rate rather, is going to be altered. They might be breathing a little faster, heavier, and that's all related. Pain might alter their respiratory rate. Stress, anxiety can increase the respiratory rate, fever and illness, medications, as well as any position changes. Changes in respiratory function could be indicative of patient deterioration. So we need to be mindful when, patients are bedbound or hospitalized. Respiratory rate should be part of our assessment. And just like with pulse, we're assessing the respiratory rate for 60 seconds. And we're assessing depth, rhythm, as well as their effort. Respiratory rate normal range is about 12 to 18 or 12 to 20. I usually say 12 to 20, kind of on the higher side. Their pattern is even, nice inspiration, nice expiration, and it's regular. There's no apneic episode where there's no breathing. There's no irregularity. They're not bradypneic, or their respiratory rate is less than 12, and they're not tachypneic, or the respiratory rate is greater than 18. So, question 3. You're assessing a patient in the intensive care unit, and you assess the respiratory rate and count 11 breaths in 60 seconds. You inspect their chest and note shallow respirations with accessory muscle use. Which action should you implement first? All right, so think least invasive to most invasive. And think really more what is pertinent based on the information that you're getting from this case. If you picked A, you're correct. It seems like they have shallow respirations. I don't think they're fast. I don't know why that says fast, but it's slower because it's 11. But their respirations are shallow, and they seem to be using more muscles. You shouldn't really need to use any muscles while you breathe. Your only muscle use is the diaphragm that's helping you breathe in and out, and that's done involuntarily. So this information gives us that the patient may be in some type of respiratory distress. And going back to the case, we're not going to sit them in the low Fowlers. We're already noticing that they seem to be struggling a little bit to breathe. Taking a temperature is not indicated. We're finding that, we need to focus on this abnormal finding of respiration. So calling their physician immediately, or maybe calling a rapid response, probably would be your next step. The fourth assessment is your blood pressure, and your blood pressure is really assessing circulatory blood volume as the heart contracts and relaxes. And with this, we'll be using a sphygmometer, which is just your run-of-the-mill blood pressure cuff, and a stethoscope. Sites to take blood pressure include the upper arm, the forearm, as well as the thigh. Upper arm and the forearm, depending on the type of cuff you have. If it's very difficult to assess an upper arm, with the cuff that you have, if the patient is morbidly obese and you don't have a cuff that adequately assesses it, you can always convert to the forearm. If an arm is not an option, then you would revert to assessing the thigh and using the popliteal pulse rather. Cultural considerations in this with blood pressure, we'll talk a little bit more about this when we get into cardiovascular, but the African American population have one of the higher risks of hypertension or high blood pressure. And non-Hispanic African men and women usually have higher blood pressure, more than 40% in the population. So the African American population will need to be a little bit more cognizant of this statistic, and be, mindful of really assessing blood pressure and assessing risk factors and assessing their education, their knowledge about blood pressure, how it can be caused, and ways to prevent elevations in pressure. Blood pressure cuffs are going to vary. The very first thing is we need to measure the patient's arm and choose the correct cuff size for their arm. We need to make sure that the cuff is covering about 80% of the circumference of the upper arm, and the cuff width should cover about 2/3 from shoulder to the elbow. All right, so just want to show you what this looks like kind of visually. The larger arm, the greater the cuff size you should apply. And there are different cuff sizes. There is the young adult, there's the pediatric cuff size, there's actually a neonatal cuff size, which is really tiny. There's a pediatric cuff size. There is the regular normal size adult, and then there's the extra large, which is usually a maroon color. The normal size is usually a blue. Neonates is white, and I forget what color the pediatric cuff sizes are. So in preparation for collecting blood pressure, you want to make sure that you've asked them if they've smoked, if you've collected information in their health history that they are smokers, or enjoy drinking, the cup of coffee. You want to make sure that it hasn't been done in the last 30 minutes because it can give you a false rating. I always say you want them to be at least comfortable, within 5 minutes. Don't take their blood pressure within the first 5 minutes of meeting them. Get them relaxed, get them comfortable, have them sitting or laying, somewhat semi-Fowlers. Do your other assessments, talk to them, build a rapport, and then after that, feet flat on the ground, not crossed, not moving, not talking, little dim lights, and then assess their blood pressure. If you are assessing their blood pressure, you want to make sure on their arm, you want to make sure that their arm is comfortable. Their back is supported, their legs are uncrossed, their palm is facing up, and their arm is resting at the level of the fourth intercostal space and not tensed up. So you want them just sitting, relaxed. Preferably, you want to put that blood pressure cuff on their skin and not on clothing, because you'll get an inaccurate reading, or you might get, if you're applying the stethoscope on clothing, you might get altered sound. You want to also make sure that you are not placing the blood pressure cuff, again, over clothing or on a site where there is dialysis surgical region. When you are when you're collecting blood pressure, you want to wrap the cuff around evenly with a little snugness. You want it over the elbow because you want to apply the stethoscope right at the brachial artery. And again, bare arm is the best to do it over, and remember, at the heart level. And you want to palpate where that brachial artery is. It's right at the antecubital fossa, right in the middle. Closest where the pinky finger is, and you'll find where that radial pulse is. And you want to press in, palpate lightly, but press in enough so that you can kind of feel where that pulse is. And this is the two-step process where you're palpating the brachial pulse and you're squeezing the blood pressure cuff at as much as you can until you no longer feel the brachial pulse. Once you no longer feel the brachial pulse, what you're going to do is you're going to deflate the cuff, and you're going to add 30 to where that pulse stopped. at the next, step, you're going to apply your stethoscope and inflate 30 mmHgs above where the radial pulse stopped, and you'll get that first beat, and you'll listen, and that first sound that you hear is your systolic reading. And at the same time, you got to keep listening and listening carefully. And once that sound starts to mellow out, you'll be going through your Korotkov sounds. That first beat is your first Korotkov sound, and that first beat is your systolic sound. And then that last sound that you hear is your diastolic sound. Make sure that you're listening carefully when it first starts and when it ends. You're also listening for the auscultatory gap, and the auscultatory gap, if a brachial pulse, or rather reading, is 144/82, if you're listening and you hear the auscultatory gap, the auscultatory gap is going to be a kind of a pause where it'll stop beating and then it'll start up again until you hear that final beat. So you want to listen, and you want to listen very carefully. And you can document the auscultatory gap being 128 to 112. And this is just an example of where the first sound was heard, where the last sound was heard, and where there may have been a gap in their blood pressure. Normal findings, what we consider normotensive, anything less than 120, and then for systolic, and then for diastolic, anything less than 80. And then when collecting the pressure, it's not going to be any different. You're only assessing using the popliteal artery that's right behind the knee. And you're performing the same exact step by checking their brachial pulse first, and then applying the blood pressure again, adding 30 to where it stopped, and then recollecting. So question number 4, I believe. You're preparing to apply a blood pressure cuff on an overweight person. Prior to putting the cuff on them, what intervention should you do first? Should you ask if they've smoked in the last 45 minutes? Have them take a deep breath? Ask them how much they weigh? Or measure their left upper arm circumference? And if you picked D, you are correct. So remember, 30 minutes is our cutoff for determining if they've smoked or drunk any beverages. We don't want them to hold their breath. We kind of want them to, breathe easy. And we don't really need to ask them how much they weigh. We're really determining the size of the cuff by determining the size of their upper arm. Okay. And then again, when we're assessing a forearm assessment, we're going to pretty much use the same, but we'll use the radial pulse as our marker. So we choose the correct size, and it might be a smaller size than what was used on the upper arm. And we are going to use, again, the radial artery as our marker, and auscultate the same exact way, systolic and then diastolic. No different, just different locations. And the thigh region, we just talked, I showed you the picture earlier, but this is if the blood pressure cannot be taken in either of the arms. And in this case, we're using the popliteal artery. We're placing either the bell or the diaphragm, whichever is easier, and we're going to proceed as we did, step 1, assess with the artery, and then inflate 30 millimeters per mercury when they are, when we figured out when their beat stopped. Orthostatic blood pressure is another important assessment to take, and orthostatic is assessing their blood pressure when they're seated and then reassessing when they are standing. So orthostatic or postural hypotension is an abnormal fall in blood pressure of at least 20 millimeters per mercury systolically and at least 10 millimeters per mercury diastolic within 3 minutes of standing upright. And if there is a gap, if there is a difference, that might be a sign of decreased circulating volume. Could be related to hypovolemia, could be related to anemia, could be related to dehydration, could be related to age. So a number of different factors can go into it. And with orthostatic hypotension, these are also patients who, if they come to us and they say that they feel dizzy or lightheaded with position changes, we need to be cognizant, maintain safety and follow precautions. But orthostatic is an appropriate assessment to conduct on these patients. And so again, we are going to place the patient in the supine position for about 5 to 10 minutes. We'll assess their pulse, we'll assess their blood pressure in the left arm. We'll leave the cuff on, and then after 3 minutes, we'll ask them to stand up, and then we'll reassess after 3 minutes. Okay. Normal findings should be no change, or there should be a slight pulse increase because the patient went from the supine position to the upright position, so their pulse might be increased a little bit. And their blood pressure and their diastolic should decrease, less than 20 millimeters. There shouldn't be an increase or greater than 20 milliliters per mercury systolic and 10 millimeters per mercury diastolic. Then the last couple of slides, we're going to go into a couple of questions, but the last slide, for this lecture talks about Healthy People 2030 and patient education topics. Patients really should understand their own vital signs and know when to report abnormal findings. And, today there are a lot of people who actually have those electronic blood pressure cuffs at home. They can get them from Walgreens, CVS, Rite Aid, whatever. And they take their blood pressures at home. Patients who are hypertensive on blood pressure medications, have congestive heart failure, have respiratory or cardiovascular diseases, those are patients who, should probably purchase a blood pressure cuff and know how to assess, number one, how to assess their blood pressure properly by using their upper forearm, but also what readings are concerning and what they should be looking for. Lifestyle modifications should also play a role in your care and education of the patients. And that includes, including exercise, changing diet, talking about what type of diet they're on and modifying their diet if it's not a healthy diet, and then including an increase in water intake. Last questions. I have 2 more questions to go through. So you're assessing a blood pressure on a patient who has a renal shunt in their left arm, so they're getting dialysis, as well as an intravenous line in their right arm. They weigh about 120 pounds and they're about 5'4". Where would you want to take their blood pressure? So think about this case scenario and what would probably be your best bet for this patient in taking their blood pressure. So remember, we said if they have a renal shunt or they're on dialysis, we should never take that blood pressure in that arm. And then in their right arm, they seem to have an intravenous line. So we can't take a blood pressure cuff when they have an intravenous line. So that actually eliminates A, it eliminates B, and it also eliminates D. So the correct answer is C. Last question. The on-call visiting nurse is triaging a patient phone calls. Which patient should they call back first? patient who reports a respiratory rate, a patient who reports a fever of 100.4, patient reports a blood pressure of 160/88, patient reports a pulse of 56, or a patient who reports shortness of breath. Now, you probably can tell me all of these are actually very concerning. So all the answers are correct, but the question is asking, which is the priority? Who they're going to call all 4 patients, but of the 4, which are they going to call first? If you answer D, shortness of breath, that's correct, because that could actually be life-threatening. They could probably be having a heart attack at that point. A temperature is concerning, and those are patients I would call back and say, I think probably might want to go to the emergency room or maybe go to an urgent center. If they have a blood pressure of 160/88, I would call them back, but those are also patients who might have hypertension and probably have a long-standing history of high blood pressure. So we'd want to call them back and maybe talk to them about if they're hypertensive, have they taken any medications. And then a pulse of 56 is actually kind of sort of normal. I mean, if their pulse is 60, if a pulse of 60 is normal, a 56 is not too far off from where that normal is. They're not a priority to call back immediately, but the shortness of breath is your priority.